Well, welcome to the next podcast, which is on selected clinical calculations, which is a nice vague term because it's actually a summary chapter that applies the types of calculation we've already learned and covered, but in a variety of different clinical situations. So you'll notice there are new formulas and new ways to apply your math skills, but there isn't any sort of new type of calculation or mathematical manipulation. So let's just apply what you already know to some different sort of clinical situations. So the first situation we're going to deal with has to do with heparin dosing. And it's an important one because heparin is a very commonly used medication, especially in inpatient situations, and has led to a lot of medication errors due to calculation errors. So it's a good example of the type of drug where you need to really apply your calculation skills. Now, a little bit of background is that unfractionated heparin is a widely used anticoagulant, and it's used for a variety of different thrombolytic diseases. In other words, it's used to thin the blood and prevent blood clots from forming, as is in the case for this question, or other times it's used to keep an existing clot from getting worse. However, determining an appropriate dose for an intravenous infusion of heparin is highly variable in clinical practice. Multiple standardized weight-based protocols have been adopted, however, and you'll see that's applied in this question later on. Now, even after heparin has been started, the dose is actually subsequently adjusted based on how well it is thinning the blood. The lab value that's used to monitor heparin is called activated partial thromboplastin time, often abbreviated APTT. Okay? Now, this value is increased by heparin. So if the APTT time is too low, more heparin is needed. Conversely, if the APTT time is too high, then the amount of heparin should be decreased or even stopped until the APTT value returns back to a desired level. All right, so it gives you a little bit of background to understand what we're trying to calculate in this question. So let's turn back to the question now. The question states, a male patient weighing 76 kilograms is placed on heparin therapy for the prevention of deep vein thrombosis or blood clot that can occur after surgery. So we want to prevent that from happening. So letter A says, how many milliliters of a heparin injection containing 5,000 units per milliliter should be administered for a loading dose of 80 units per kilogram? Letter B asks, what should the infusion rate be in milliliters per hour using a solution already made up that contains heparin at a concentration of 25,000 units per 500 milliliters to administer a continuous infusion at the rate of 18 units per kilogram per hour? And lastly, letter C says 6 hours after starting the heparin therapy, the patient's APTT value is found to be 75 seconds. Basically, use a protocol that I'll show you later to determine whether or not the infusion needs to be adjusted. All right, so really 3 questions in one. I'll remind you for all of these questions that we always cover in these podcasts, it's important to go ahead and rewrite the information we know. Before we try to start in and dive into the calculations, let's rewrite what we know in a useful format. So what I would tell you is to write down, what do we know about the patient? What do we need to know about the patient? For this question, the only thing we need to know is that they weigh 76 kilograms. And that's important because a lot of the dosing is weight-based. So we know this patient's weight is 76 kilograms. Now, what do we know about the drug? This question is made a little bit confusing by the fact that heparin is administered in 2 ways. A, an initial loading dose that we want to have at 80 units per kilogram. And we're going to use a drug, and as you can see the picture of the vial in this picture, a drug vial that contains 5,000 units per milliliter for its concentration. Secondly, we're also going to calculate how to provide an infusion, a continuous infusion dose based off of 18 units per kilogram per hour. And here we're going to use a different form of heparin. Here we're going to use a bag that's already been made up that contains 25,000 units per this 500 milliliter bag of heparin. Okay, so don't get the loading dose confused with the infusion dose. We've got 2 different products that we're going to have to calculate. So let's do it. So on this slide, I've rewritten the information, but let's start with letter A. As a reminder, it asks for how many milliliters of the heparin injection that we're going to do for the bolus dose. So to start with this, I'll go ahead and always show you my formula to begin, or my equation to begin with, and we'll kind of walk through it. But this question wants to know the dose of heparin, and it's based off of weight. So where we're going to start with the fact is that this patient weighs 76 kilograms. We're then going to multiply in a way that we're going to watch our units cancel and get to the final answer we want, which is in milliliters. So we'll start off with 76 kilograms and then multiply that by the dosing amount. And the dose for the bolus is 80 units per kilogram. So we multiply by 80 units over 1 kilogram so that kilograms cancel, and that will give us the total number of units this patient needs. Next, we got to then convert the total number of units to the volume of this injectable. So again, we're going to multiply it by the concentration, though, expressed as 1 milliliter over 5,000 units. Okay, and we do it in this way so that the units of units cancel, and we'll have our final answer with the units of milliliters. So if we do that math and take 76 times 80 divided by 5,000, we get the number of 1.2, and we can see both our units canceling all the way across. We end up with the units of milliliters. So the answer to letter A would be 1.2 milliliters of this 5,000 units per mil injectable vial to give the dose that we need. All right. Now let's move on to letter B. Letter B is not about the bolus anymore. It's about the continuous infusion. So it wants to know what the infusion rate in units are important here, milliliters per hour, if we use a solution that contains 25,000 units per 500 mils, and we want to administer that at 18 units per kilogram per hour. Okay. So again, the question is, where do we start in this question? And again, the dosing rate is based off of weight. So let's start with the patient's weight. And again, the patient weighs 76 kilograms. So if we take 76 kilograms times the dosing amount, which is 18 units per kilogram per hour, so that kilograms will cancel and will be in units per hour. Then we're going to want to convert our units into milliliters. So we're going to multiply it again by the concentration expressed as 500 milliliters on top over 25,000 units. Doing this, the units of units cancel again. And if we do the math all the way across with 76 times 18 times 500, and then divide that by 25,000, you should get a number of 27. And as you can tell, we have milliliters on top and hours on the bottom since it didn't get canceled out. So setting up the equation and multiplying across like that allows us to get our final answer of 27 milliliters per hour. All right, and we've answered the first two parts to this question. So the third question, a part of this question, was 6 hours after heparin therapy is initiated, the patient's APTT value was found to be 75 seconds. Adjust the infusion rate in milliliters per hour according to the high-dose heparin protocol. So what I show you here is an example of a heparin protocol. As we said, if the APTT value is below a desired value, and if you look on this table, you can see a desired value is between 46 and 70 seconds. So if the APTT value is below that, then we don't have enough heparin, we need more heparin. If the APTT value is above 70 seconds, then we have too much heparin, which means the blood is too thin and the patient is at risk for a serious adverse event such as a bleed. So we want to decrease the dose or the administration rate if we're above 70 seconds. And so that's kind of the take-home message, and that is exactly how they would manage a patient on heparin in the hospital. So given what they tell us in letter C, what I show you here is that our value of 75 seconds puts us within the range of 71 to 90 seconds, and the instructions on the protocol therefore, are to decrease the infusion rate by 2 units per kilogram per hour. I'll remind you in letter B that we just did, the value was 18 units per kilogram per hour. Now we're being told because of the APTT, we should decrease it by 2 units per kilogram per hour. So the math is very much like what we just did, but taking that into consideration. So we'll start with this patient's weight again at 76 kilograms. We then multiply it by our modified amount. So instead of 18, we're going to subtract 2 from 18 and actually multiply it by 16 units per kilogram per hour. That is 2 units less than what we had calculated previously for the initial infusion. All right, so we'll multiply by that. Kilograms will cancel. We then multiply again by the concentration of the solution. We're still using the same IV bag, but we're going to multiply by 500 milliliters over 25,000 units. So again, the units of units cancel. And what we get in the end, if we take the 76 times 16 this time, times 500 divided by 25,000, you should get the number of 24. And the units that remain would be milliliters per hour, which then answers this question. So hopefully we're able to follow that along and answer our heparin dose question. The next question is a really good one, and it has to deal with an example of what we call Equianalgesic dosing calculations. And this is very important. I'll talk a little bit more about that on the next slide, but these are some calculations pharmacists are doing more and more of in your role as kind of a safety manager for patients that are on different types of opioid, pain, or analgesic medications. So let's look at the question first. It says, a patient is receiving morphine sulfate intravenously via a patient-controlled analgesia, abbreviated PCA, pump. The concentration of the solution is 15 milligrams per milliliter and is being infused at a rate of 0.1 milliliters per hour. All right, are you already having information overload? It gets worse. The patient may actually access a 2 milligram bolus dose every hour for breakthrough pain, and is currently using an average of 8 doses per day. Okay, so that's how they're managing their pain. The patient's caregiver, probably a family member, maybe a spouse, requests that the patient be converted to a fentanyl, different opioid drug, but in the form of a transdermal patch, the brand name of which you may have heard is called Duragesic, because they feel it is a safer dosage form. It's certainly easier to administer than having to give an IV infusion. So the question is, what strength of fentanyl patch would be most effective for this patient? So essentially, we want to go from an IV-based, patient-controlled analgesic pump therapy management that manages both continuous pain as well as breakthrough pain management using this morphine setup. And we want to convert to an equal analgesic. We don't want them to go through pain. We want to put them on a dose of fentanyl in the form of a transdermal patch that will manage the pain at the same level that the morphine has been doing. Okay, and that is exactly the type of calculations many pharmacists are involved in when a patient is, for example, discharged from an inpatient or a hospital setting to be taken care of at home, or maybe in more of a hospice setting, and they want to go from a more complicated dosage form, an IV form, to a sometimes oral form, in this case, a topical form with the patch. All right, so with that in mind, let's rewrite this information. As I alluded to, there is a lot of information. Let's organize it so it makes sense. So first, let's rewrite what is the current drug therapy. The current therapy for this pain management for this patient is to use a morphine infusion continuously with a concentration of 15 milligrams per milliliter and at a rate of 0.1 milliliters per hour. That continuous infusion of that concentration of morphine hopefully controls this patient's pain. It's the controller dose. However, patients can still experience breakthrough pain, and this patient is as well. 8 times per day, this patient is having to push a button to give themselves a little bit more morphine because they're in some pain. Every time they push that button, like we said, 8 times per day when they push that button, they're giving themselves an additional 2 milligrams. So the patient's total daily morphine will be an addition of both their continuous controller dose as well as this breakthrough dose. And so you'll see that in the calculations. Now, what do we want to, the whole idea is to take now that we kind of understand what the patient is using, what do we want to convert that to? What we need to do is calculate what strength of a transdermal patch of a different drug. So we're not going from morphine IV to morphine patch. We are going from morphine IV to a different drug, fentanyl transdermal patch. So we're going to have to be able to convert the pain level managed by one drug to the pain level managed by this different drug. All right, so there's all that information rewritten. Where do we start? We're going to start by calculating this patient's total daily. And again, I put in parentheses to remind you, when I say daily, I mean 24 hours. So within 24 hours, what is the total amount of morphine that they are receiving currently? And I don't care if that morphine is from their continuous controller dose or from their bolus breakthrough dose. We're going to add all of those together. So it doesn't matter where, we need the combination of all of their morphine. So let's start with their infusion. Okay, so if we're going to calculate how much morphine they're getting from their infusion, we'd start with, and this is what's tricky, we wanted to know their dose for a day or 24 hours. So let's start with 24 hours. We're going to take 24 and multiply it by the infusion rate. They were getting this drug infused at 0.1 milliliters per hour. And so you can see that when we multiply across, hours will cancel and will be in units of milliliters. Okay. Next, we'll multiply it by the concentration of the drug fluid being infused. And remember, the dose was 15 milligrams over every 1 milliliter. And if we set it up this way, milliliters will cancel, and 24 times 0.1 times 15 equals 36. And the units that remain when we cross-multiply in this way are milligrams. So what we've done is calculated for the infusion. For within 24 hours at those parameters, they will be receiving 36 milligrams. All right. Now, we've also got to think about how much morphine they're getting from their bolus doses. So let's start with the fact that they tell us in this question, this patient is pushing the button 8 times per day. Okay, so they are receiving 8 doses. So we're going to start with 8 doses and multiply it by the fact that we were told that there are 2 milligrams in every dose. So with 2 milligrams over 1 dose, you can see doses cancel. And when we take 8 times 2, that says that this patient is receiving 16 milligrams of morphine through their bolus doses. All right. So the next step is to calculate the total daily morphine dose for both. So basically, we're going to add the 36 milligrams they're getting from the infusion to the 16 milligrams they're getting from the bolus, and you add that all together. You can see this patient is receiving 52 milligrams of morphine per day. And I love my little animation there, so hopefully that helped. All right. Now, keep that in mind. 52 milligrams of morphine per day. All right, so this is an important table. And before we get back into answering this question specifically, I just wanted to have you understand that what a lot of pharmacists do now, and a part of their patient care, is that for many patients, they're often started on one opioid analgesic. And again, if you look at this table on the right-hand side, you can see a long list of medications. All of those medications are opiate-based pain medications or analgesics. For whatever reason, they're started on one of those and need to be switched to another. But if you look at the factors here, these are called MME factors, it shows you how relative potency is compared back to morphine. So this MME stands for morphine milligram equivalent. It's how you can convert the amount of one opioid, convert that to an equivalent amount of morphine. So we don't go, for example, straight from tramadol to oxycodone. You can't just convert a strength of tramadol to a strength of oxycodone. What you do is you take the strength of tramadol, convert it to its morphine milligram equivalent, its MME, and then you can take that MME value from this table for the other opioid and convert from that back to the new one called, like, for example, oxycodone. So I don't want to go through all those math right now in this question. I think it's covered in the textbook chapter as well. But it is an important table. It's an important skill that pharmacists are having to do. Okay, so getting back to our question, coming back to here, because the fentanyl transdermal patch is a little bit different. At this point, we know we need 52 milligrams of morphine equivalents converted to an equivalent amount of fentanyl in a transdermal patch. And you can see on this table, fentanyl is not included because the transdermal form of this is a little bit different. So what you would need to do is go to a drug information resource and look up the drug you want to convert to, which is fentanyl, and find some information. So here you can see on the left-hand side, this is a table I got from LexiDrugs or LexiComp online. So I typed in fentanyl, pulled up fentanyl, went to the dosing section, and found this table down below there. That basically, for a variety of different current analgesics and the dose, gave me the corresponding strength of the fentanyl patch to switch to. So if we look on for morphine, and we're giving it IV, and it gives on the right-hand side different total daily doses. Ours was 52. So in the column, the third column over where it says 38 to 52, that would be our dose of morphine. So it shows below there that the corresponding strength of patch to give would be the 75 microgram per hour patch. That patch should provide the same analgesic relief as somebody who is receiving 52 milligrams of morphine per day. And that's the final answer to this question. Okay. The next question is very different, and it's about calculating renal or estimating renal function by using different clinical equations. All right. This also is an extremely important skill for all pharmacists. As you probably hopefully know that most drugs, once you administer them in the patient, are eliminated from the body either through hepatic or liver metabolism and or in combination with renal excretion through the kidney. So the kidney's ability to filter the blood and remove the drug from the body is extremely important. When the kidney function is decreased through age or disease or whatever reason, then a dose of the drug won't be eliminated as quickly and can build up and become toxic. All right? So obviously, we need to be able to estimate a patient's renal function since it's not something that can be directly measured. So we use these formulas that have been validated through clinical trials as a way to be able to estimate kidney function. The only other additional information before we jump into this question is, because there is a question about body surface area. And body surface area is important for kidney function only in the sense that a small kidney, think about a kidney from an infant or a newborn, it's physically much smaller. Guess what? That smaller kidney, even if it's very healthy, is not going to function as well as an adult's kidney, which is much larger. As it grows, as we grow and progress, our body changes, the kidneys get bigger, and the bigger the kidney is, the more it can filter. So that doesn't mean it's healthier than a smaller kidney, but truly the function of a kidney will be higher in a larger kidney. So sometimes when we want to estimate somebody's kidney function, we do have to consider their size. They're not weight so much as their body surface area, because the size of a kidney has been shown to be proportional to body surface area. The larger the body surface area, the larger the kidney. So we can use that as a way for kind of making sure that our estimate is reasonable for the size of that individual's kidney. All right, with that as enough background, let's read the question. It says, to calculate the creatinine clearance using both formulas given in your textbook, it was the Joliffe and the Cockcroft-Gault equations. So we're going to do it twice using two different formulas. And we're going to do that for a 24-year-old male patient who weighs 70 kilograms and has a serum creatinine value of 1 milligram per deciliter. All right. And letter B says, if this patient also is 5 feet 8 inches tall, go ahead and adjust your calculated creatinine clearance based on their body surface area. All right. So let's rewrite some information and just think about one additional idea. So in this case here, it's not about drugs yet so much as we want to just figure out what is their kidney function. So we need a lot of patient information to do that, to use these formulas. So what we know is that our patient is 24 years of age. Our patient is male. They weigh 70 kilograms, and they stand 5 feet 8 inches tall. And lastly, they've had some blood work, and one of their lab values were reported as the serum creatinine was 1 milligram per deciliter. Now, don't get that confused with the creatinine clearance. What we want to calculate is the creatinine clearance, meaning the clearance of creatinine from the body and into the urine. We do that by measuring how much creatinine is actually still in the blood. So the serum creatinine represents the level of this creatinine that's in the blood, and we're going to calculate the kidney's ability to actually remove it from the blood. So we need a serum or a blood value to be able to do that. So with that information, we should be able to proceed on with our actual calculations. Now, before we jump into the formulas to actually calculate creatinine clearance, and we're going to need to convert and calculate some things like ideal body weight and body surface area and some other information we need before we can use the formulas. So our first step is to do this. Let's convert the height that we were given in the question from feet and inches, into centimeters. So to do that, I kind of show you my equation here. I start with the fact that they are 5 feet, and I convert 5 feet to inches by multiplying by 12. So this patient is 60 inches plus an 8 additional inches because they were 5 foot 8 inches. So 60 inches for the 5 feet plus the additional 8 inches means this patient stands 68 inches in height. Then I'm going to convert that to centimeters by multiplying it by the conversion of 2.54 centimeters per inch. So 68 times that means this patient stands 173 centimeters in height. I'm going to need that number in one of my formulas. All right, so let's move on. Now we'll need to calculate this patient's body surface area. To do that, we'll use the Mosteller formula that you've done in a previous chapter, and that formula was to take the square root of the height in centimeters when it's multiplied by the weight in kilograms and then divided by 3,600. Okay, so let's use that formula. So if we put our numbers in there, basically we take 173 centimeters times the patient's weight of 70 kilograms, divide that by 3,600, and then don't forget to take the square root. So when we do all of that math, you should get a final value of 1.83, and the units for body surface area are metered squared. All right, we're getting closer. Now we need to calculate this patient's ideal body weight. And I'll remind you the ideal body weight formula is slightly different depending whether you're male or female. So this patient's gender is male, so the formula for the ideal body weight is given here at 50 kilograms plus 2.3 times each inch over 5 feet. So for this patient, it would be 50 kilograms plus the number 2.3 times 8, since they are 5 foot 8 inches. So if we do that math and add that together, our final answer for this patient's ideal body weight is 68.4 kilograms. So these three numbers are going to be important as we move forward. We needed to do this before we can even attempt to solve the formulas for the different creatinine clearances. Okay, so now we're ready. So I've rewritten the information here, including the ideal body weight and the body surface area that we just calculated. So now what we can do is calculate the creatinine clearance using the Gillespie equation. Now, a little bit of background I'll just give you for the Gillespie equation is that it is still commonly used, but it's really reserved for when acute patients who are in acute hospital settings, if their serum creatinine values are changing frequently, sometimes during the day or from day to day, if their kidneys are actively changing their functions, then the Gillespie equation is actually very valuable. If it's not, if the serum creatinine is a stable value, then they'll use more of the Cockcroft-Gault one we'll do subsequently. But for now, let's practice using the Gillespie equation. So I'll give you this equation straight from your textbook. That's just something to look up or to memorize if you needed to. And it is to take the numbers 98 and subtract 0.8 times the patient's age after you've subtracted 20. So, and then you take all of those numbers and divide it by the serum creatinine. So, if we do that for a patient specific, then we would be taking 98 minus the 0.8 times, reminder, this patient was 24 years of age, so you would take 24 minus 20, so that would be 4 times 0.8, that minused from the 98, and then divided by the serum creatinine here, which was 1 milligram per deciliter, would give us a total final value of 95 milliliters per minute. And the units for these creatinine clearance calculations are in milliliters per minute. So hopefully you could set up those numbers and solve that math. That's just part of this course, is to be able to plug and chug your numbers carefully and accurately in your calculator. Next, let's do the second and probably more often used creatinine clearance estimate, is to use the Cockcroft-Gault equation. Okay? And this is one I'm told you really end up having to memorize even for your board exams for the NAPLEX. It's one that you're probably expected to be able to do in practice. So the formula is to take, and it's a very different, and it was a different clinical trial. It still estimates the same thing. We're still trying to estimate the clearance and the kidney function in milliliters per minute, but a different formula. It's 140 minus the patient's age times, and in this case, the ideal body weight, then divided it by the number 72 times the serum creatinine. All right, so if we look at the patient-specific values, it would be 140 minus the patient's age at 24 times the ideal body weight that we calculated at 68.4 kilograms. And then divide that by the number 72 times the patient's serum creatinine of 1 milligram per deciliter. If you do all that math correctly, you should get 110 milliliters per minute. Okay? So those are the two different creatinine clearance equations that are often used, and hopefully you were able to mathematically solve and get the right numbers. Now, we want to make this last one, and we're just going to focus on the Cockcroft-Gault here. Let's see and adjust it for body surface area, because this patient's shape, their body size, may be bigger, maybe smaller. We need to really refine their value and adjust it for the patient's body surface area. So to do that, it's pretty straightforward. You would just calculate the creatinine clearance just like we did. Okay? But then what we're going to do is multiply it by this patient's body surface area that we calculated, divided it by, and this is kind of a magic number, 1.73 meters squared. Where the heck does that number come from? 1.73 meters squared is simply an average normal adult body surface area. Just like we kind of say a normal average adult has about 70 kilograms in weight, a normal average person's body surface area is 1.73 meters squares, which probably means no one's really is exactly that, but on average, you take a population and you add everyone's up and divide it by the total. The average body surface area for normal adult populations, non-obese, non-underweight, a normal weight, healthy weight individuals, the average body surface area is 1.73. Okay, that's why we're standardizing it. We're going to adjust the creatinine clearance for how close this person is to this normal 1.73 meters squared. So to do that, we take the creatinine clearance we calculated, the 110 milliliters per minute, and multiply it by this patient's body surface area of 1.83 divided by the normal average body surface area of 1.73. And if we do that, then what we get is our final adjusted creatinine clearance at 116 milliliters per minute. And that value is probably a little bit more accurate than the 110 would have been, because we've gone to the additional effort to adjust it down to what a normal average person's value would be in comparison in their body surface area. So hopefully that helped. And again, I would still say the big part of this formula, this course, is to make sure you can do that math. It isn't so much about memorizing the formulas and making sure when would you use one creatinine clearance over the other. That's something that we'll certainly cover a lot more, sometimes in lab and also in therapeutics. But being able to calculate the creatinine clearance correctly is an important skill. All right. The next question will go a little bit further in terms of using ideal body weight and adjusted body weight in calculating doses for different drugs. And the drug in this case is immune globulin. Okay, and it has to do usually with the treatment of primary immunodeficiencies, where you can't make your own immunoglobulin. And the primary immunodeficiency disease, or often abbreviated PI, it really actually consists of more than 350 rare and chronic disorders, different types of diseases, different causes. But in the end, all of these diseases cause an incomplete immune system. So the immune system cannot generate immunoglobulins like a normal people. Okay, these disorders are not contagious. They're often present at birth. It's just an inherent ability that can keep the body from producing these antibodies. So the drug used to treat these primary immunodeficiencies is human immunoglobulin, which is actually interesting. It's not, unfortunately, synthetically created yet. It's actually purified from human plasma in a multi-step, very complicated process where they use different alcohol concentrations under very specific temperatures and pHs and protein concentrations, and they can basically extract the immunoglobulins from normal human plasma and basically purify it and use it therapeutically. And that's the drug being used in this example. So let's talk about this question. This question says that DT is a 61-year-old female patient with the primary humoral immunodeficiency. She is 5 feet 6 inches tall and weighs 303 pounds. The dosing range for this human immunoglobulin by the VIGAM is a range of 300 to 800 milligrams per kilogram given intravenously every 3 to 4 weeks. So basically she gets this dose about every month or so to keep her immunoglobulins up. Now, this patient's the dose, the weight that we're going to use, though, for this needs to use their adjusted body weight, should be used for dosing, especially since she is obese. Okay, we need to give her enough immunoglobulin to protect her bones, her muscles, her organs, but we don't want to give her too much antibody because we base it off of weight of fat. The fat inside of her doesn't need immunoglobulins. So just to use her actual weight would overestimate how much drug she needs. So in the end, we want to know what the dose would be in grams for this patient, but we're going to want to use an adjusted body weight, not an actual body weight. Okay? So let's rewrite the information that we need here. So what we're going to need to be able to correctly dose this drug for this patient is to say that what we know and need to know about this patient is that this patient stands 5 feet 6 inches tall and weighs 303 pounds. Our drug information is that the dose we want is 300 to 800 milligrams per kilogram, but the kilogram dose we're going to base off is an adjusted body weight to avoid overstating the dose because this patient is obese. All right? So let's do it. The first step we're going to want to do is to convert this patient's actual body weight from pounds to kilograms. Okay, so we're going to start bringing up some terms here, so make sure you understand what we are doing is converting their actual body weight to kilograms. To do this, we take their actual body weight, 303 pounds, and multiply it by the conversion of 1 kilogram per every 2.2 pounds. Pounds will cancel, and you can see that 303 pounds is equivalent to, or equal to, I should say, 137.7 kilograms. Easy breezy. Now, we have to first, to get to adjusted body weight, we have to start with ideal body weight. So don't get confused. We just talked about actual body weight. Now we are going to calculate ideal body weight. We're going to use the formula given here, and remind you, it is now specific by gender, so the ideal body weight for females starts with 45.5 kilograms. And then you do the same thing where you take 2.3 times each inch over 5 feet. So for this patient, we would start with 45.5 and add to it 2.3 times 6, since she stands 5 feet 6 inches in height. So this patient's ideal body weight is actually 59.3 kilograms. Okay. Why did we need to do that? Well, because what we actually want to do is calculate this patient's adjusted body weight. And you can see here that's abbreviated AJBW. Don't get that confused with actual body weight, ABW. Adjusted body weight is AJBW. And that formula is to take and start with the ideal body weight and add to it. So it's going to be the ideal body weight plus, and what you're going to add to it is to take the actual body weight minus the ideal, so find the difference between those two, and then multiply that difference by 0.25. So we're going to raise the ideal body weight by 25% of the difference between actual and ideal. I don't know if that helped restating it that way. All right, so for this patient, what we're going to do is start with their 59.3 kilograms. That's the ideal body weight that we calculated. Add to it, and you can see their actual was 137.7. We subtract 59.3 from that, and then from that difference, we multiply that by 0.25. That's what we get added. So if you do all that math correctly, you then should be able to see that their patient's adjusted body weight is actually 78.9 kilograms. And it should also make sense. Compare that to the ideal body weight. It's more. Why? Because we started with the ideal and we added to it. But it's not going to be nearly as high as the patient's actual, which was 137, right? We don't want to use their actual. That would be too much drug. So it's basically cutting 25% of the difference between the ideal and the actual to be able to calculate a more acceptable body weight for various drugs. And in this case, for our drug here with the immunoglobulin, remember, it wanted us to calculate the dose range in grams based on adjusted body weight. So let's go ahead and do this. And what I'm going to do is showing you both formulas for both the high dose, the 300 milligrams, and the low dose was 300 milligrams. The high dose was 800 milligrams. You solve them the same way. So I'll just show you both. Let me just read through the low one. Let's start with this patient's adjusted body weight, right? 78.9 kilograms. And to find the low dose, we would times 300 milligrams per kilogram, so you can see that kilograms will cancel. Then multiply that and convert it to grams. Remember, we're in milligrams. We've got to convert our final dose into grams. So we'd multiply it by for a fact that every 1 gram has 1,000 milligrams. That way milligram units cancel, and our final answer is in grams. So 78.9 times 300 divided by 1,000 gives you 23.67 grams. You solve the higher dose the same way, but you use 800 milligrams, and so you can see the formulas there. And in the end, the final dosage range here, now that we know that this patient's adjusted body weight is 78.9 kilograms, using that times the formulas, the low dose for this patient would be 23.67 grams, up to a high dose of 63.12 grams. That would be the final dosage range for this patient based off of their adjusted body weight. Moving on, last set of calculations here have to do with clinical laboratory test calculations. And you're going to be getting all sorts of clinical laboratory values that you're going to have to read and interpret as a part of a pharmacist's job to review to make sure their drug therapy is safe. This example talks about a specific drug level for theophylline. Your book does a good job of showing you examples for like lipid values. You'll get an HDL or an LDL or a total cholesterol value. What's important is then, well, is their drug that they're on, say for example atorvastatin or rosuvastatin, is that drug doing what it needs to do, or do we need a higher dose or a lower dose? And you adjust drug therapy oftentimes in relation to certain lab values. Now, let's talk about this one specifically. Let me read the question first, and then we'll kind of go through this graph here and explain why this is important. It says, the normal blood level of theophylline is within the range of 0.55 to 0.11 millimoles per liter. Okay, so looking at this graph, what do we mean? That is, it shows you that when you give, and the graph here on the y-axis is the plasma concentration of the drug. At time 0, there's no drug in you, there's no drug level. As soon as you swallow or administer the drug, clearly the drug disperses within the blood and raises its level up into some sort of therapeutic range, some sort of plasma concentration. What we want is that the plasma concentration of whatever dose we give to be high enough that we get into the desired response range. You can see the line going across there for desired response. But we don't want it so high that it goes above the top where it says adverse response. So if we go outside of the green up until the red area, we would be getting side effects. We call that the toxic level. So we don't want to go above the toxic level, but we also don't want to be below what we call minimal effective concentration, or this idea of desired response, or we'd have a subtherapeutic response. So the difference between the desired concentration we want and the adverse concentration, where we don't want to go above, that is called the therapeutic window. We want our drug levels to stay within this therapeutic window. And we just said for theophylline, normal blood levels that we'd like to see are from no less than 0.55 to no more than 0.11 millimoles per liter. That's the units that the concentration gives us in the question. All right? So now the question says, determine the amount range, but in different units. In micrograms of theophylline, that would be contained in a 5 milliliter blood sample, okay, to fall within this range. So instead of 0.5055 millimoles per liter, what would the low level be if we express it in micrograms per 5 milliliters? Same thing with the upper. What would the concentration be instead of 0.11 millimoles per liter? What would that value be expressed in micrograms per 5 milliliters? All right. So let's rewrite the information that we know. What we want to do is convert our normal expressed blood levels of 0.55 to 0.11 in millimoles per liter into micrograms per 5 milliliters. The only additional information that we need before we go forward that they give us is the molecular weight of theophylline is 180.17, because we're going to have to convert from weight to moles. So that's why we need the molecular weight. So that's the information we need to answer this question. So with that rewritten, what are we going to start with? All right, so here's the deal. At each concentration, we want to determine the micrograms of theophylline in a 5 milliliter sample. So we're going to start with the fact that we're going to have a 5 milliliter sample. Okay, and both the high value and the low value are worked the same. So I show both. The top is solving this for the low value of 0.55 millimoles. The equation on the bottom shows you the math to do it for the higher concentration of the 0.11 millimoles. All right, but it's worked the same. And let's do this step by step. The first step is the fact that, okay, we're going to have a 5 milliliter sample. All right, let's convert 5 milliliters, though, to liters, because our units, our concentration, are in liters, not milliliters. So all I have to do is multiply by the fact that there is 1 liter in every 1,000 milliliters. So 1 liter per 1,000 milliliters. All right. Then, now we're in liters, we can multiply it by the concentration we're interested in. So on the top, it was 0.55 millimoles per liter. On the bottom, it was 0.11 millimoles per liter. Units of liter will cancel, and we will now be in millimoles that we need. The next step will be convert millimoles to milligrams. We need to go from the number of molecules, i.e. moles, to the amount of weight. So to do that, to convert moles to grams or millimoles to milligrams, you'd use the formula weight. All right. So what I'm going to do is keep everything in milli. All right. So I'm going to multiply by the fact that there is 180.17 milligrams for every 1 millimole. And that's just the formula weight in milligrams over the 1 millimole. So you can see the units of millimole will cancel, and now I will be in milligrams. But I still have one more conversion to make because we wanted to know the number of micrograms. So I now multiply it by the fact that there is 1,000 micrograms per every 1 milligram. That milligram units cancel, and my final answer here will be a number in micrograms. So if you do all that math all the way across for both of these, you should match my numbers, 49.5 micrograms for the low concentration and 99 micrograms for the high concentration. But I will remind you, those are the weights present in what? In 5 milliliters. So the revised range that we could express that in, instead of saying that in millimoles per liter, we could say that the normal theophylline blood level should be 49.5 micrograms per 5 mLs to a total of 99 micrograms per 5 mLs on the high end. All right. However, that's not the way you're going to see the values expressed in a clinical report. That's the answer to this question, but I wasn't happy. I wanted to go a little further. Because, for example, on the top here on the right, I show you, this is how you would normally see theophylline concentrations expressed. In this country, you would see them in milligrams per liter, not per 5 milliliters. So let's take our answers and go one step further and actually see if we match where it says their therapeutic range is 10 to 20 milligrams per liter. Is that what, in fact, we actually calculated? So to do this, I show, again, the equations for both the low and the high. And all I'm doing here is taking our answer from above. So, for example, on the left-hand side with the low concentration, we said that was equal to 49.5 micrograms over 5 milliliters. So if I convert that from milliliters to liters, I would multiply by the fact that there's 1,000 milliliters per every liter. So now milliliters cancel. And then to convert from micrograms back to milligrams, I multiply it by the fact that in 1 milligram, there is 1,000 micrograms. So just hopefully you can see how the units cancel. But if you do that math, for the example for the low, fine. If I take 49.5 and divide it by 5, and then multiply by 1,000, divide by 1,000, you should get a final value of 9.9 milligrams per liter. Doing the same thing over on the right-hand side, you can see our 99 micrograms per 5 mLs is the same as 19.8 milligrams per liter. So rounding just a little bit, you can see your low value was 10 milligrams per liter. Your high value was essentially 20 milligrams per liter, which matches the picture I show you on top that shows that is what you would expect for a normal range for theophylline. So hopefully this was helpful. These questions are certainly a little more complicated than ones we've done in the past as far as setting them up, but the math is the same. Once again, if you take the time to correctly set up your formula, check your units, then the math is generally relatively simple. So hopefully this was helpful, and thank you very much.